Okay, let's unpack this. You've put together quite a stack of notes here, all focused on rheumatology. I mean, that's an incredibly complex area, isn't it? Joints, muscles, connective
Oh,
tissues.
absolutely. It really is a vast landscape.
Yeah.
And these conditions, they often involve such intricate immune processes, they can affect the body in so many different ways.
Right. So our mission in this deep dive, using your sources as our guide, is really to find the clearest path through all that complexity. We want to pull out the absolute most important bits of knowledge, the crucial distinctions that, well, make sense of it all.
Yeah, find those aha moments.
Exactly. Leave you feeling genuinely well-informed and fast. Get ready because we might see some surprising connections and really understand why certain things are flagged as, critical.
Sounds good.
So, diving right in, your notes very wisely start right at the foundation, what makes a joint work normally, and then what happens when things go wrong.
Right. And the sources lay out that basic structure of a healthy joint pretty clearly. You've got those ends of bone covered in that super smooth articular cartilage,
Like glass.
pretty much. And the whole thing's encased in a capsule, lined by the synovial membrane. That's what makes the synovial fluid.
Which is the lubricant.
Exactly, a lubricant, and it feeds the cartilage too. And then around that, you've got the supporting players, like bursae, tendons, all holding it together.
Okay, so that's the ideal state. But, I mean, rheumatology is really about the problems, isn't it? Your notes show this really critical distinction between degenerative and inflammatory joint issues. What's the core insight there?
This is probably one of the most important things to grasp right from the start, based on your sources. So in a normal joint, everything glides smoothly. But in degenerative conditions, like osteoarthritis OA,
Right.
the primary problem is the physical breakdown of that smooth cartilage. Just wears down. And the bone underneath reacts, it thickens up, that's sclerosis, and it forms spurs, osteophytes.
Spurs, yeah.
Right. The joint space literally gets narrower. Now, there can be some inflammation, but it's usually sort of secondary,
Yeah.
the consequence of the breakdown, not the main thing driving it.
Okay, so like mechanical wear and tear leading to some collateral damage. And inflammatory arthritis, how's that different?
Fundamentally different.
Yeah.
Here, the source of the problem is inflammation of the synovial membrane itself, that's synovitis.
Okay.
And this synovial inflammation, it pumps out excess fluid, causing swelling, effusion, and it releases enzymes and cytokines that actively attack both the cartilage and the bone. You get erosions, literally holes being eaten into the bone. The inflammation is the primary culprit here, driving the destruction.
Wow, okay. That distinction feels absolutely critical for sorting things out later. It's not just damage, it's how the damage is happening. And your sources then connect this to the immune system, which is often, well, misbehaving in these conditions.
They do. They introduce the basic ways the immune system can overreact
Yeah.
using those hypersensitivity types. Type A is the immediate stuff, like allergies. Type 2 is antibody-mediated, where antibodies attack cells directly, like in some kinds of anemia.
Okay. And type 3, that seems particularly relevant to some of the conditions mentioned in your notes, like lupus.
Type 3 is definitely key. This is where you get these antigen-antibody complexes forming in the blood, and then they get stuck in tissues, triggering inflammation wherever they land. Your sources point to systemic lupus erythematosus, SLE, as a classic example. These complexes deposit in places like the kidneys, joints, skin.
These complexes causing trouble everywhere. And type 5.
That's cell-mediated or delayed hypersensitivity. This involves T cells directly attacking cells or releasing inflammatory signals. Contact dermatitis, like poison ivy, that's a familiar example outside rheumatology. But T cell activity is crucial in conditions like rheumatoid arthritis, RA, or some forms of myositis.
Got it. The sources also mention the key immune cells involved.
Yes, just briefly covering the roles. Neutrophils are like the first responders, macrophages are the cleanup crew, but also signalers. B cells are the antibody factories. And T cells, well, they're kind of the conductors, recognizing threats, directing the response, or sometimes suppressing it.
And connecting this immune system to sort of disease susceptibility, there's this whole concept of immunogenetics and HLA molecules.
Yeah, this is where your genetics come into play with disease risk.
Hmm.
HLA molecules, they're MHCs in humans, are proteins on our cells that basically display little bits of proteins, antigens to T cells. It's how our immune system recognizes self versus non-self.
Okay.
And certain variations in these HLA genes make you more prone to developing specific autoimmune conditions.
Like the specific ones mentioned in your sources, those seem important.
Oh, absolutely. The sources highlight some really strong links. For example, HLA-B27 has a very strong association with conditions like ankylosing spondylitis, AS, and reactive arthritis, RAA. It significantly increases the risk.
Okay.
Then you have HLA-DR4 and DR1 linked to rheumatoid arthritis, RA, and HLA-DR3 associated with Sjogren's syndrome, SS, and SLE.
So if you have one of these HLA types, does that mean you're definitely going to get the disease?
And this is a really crucial insight from your sources, a choosing wisely point they emphasize. Absolutely not. These HLA types increase your relative risk, your likelihood, compared to someone without that gene variant. But, and this is vital, they are not diagnostic on their own. Right. Having HLA-B27 doesn't automatically mean you have AS. You need the whole clinical picture, the symptoms, the imaging. Your sources are very clear. You don't make a diagnosis just based on a gene test.
That's a key practical takeaway then. Genetics might load the gun, but other factors probably pull the trigger.
Exactly.
All right. With those foundational concepts down the anatomy, the immune basics. Let's get practical. Someone comes in with joint pain. Where do your sources guide you to start sorting through the possibilities? What's the first step?
The very first fork in the road, according to the clinical approach described in your notes, is that fundamental distinction we just talked about. Is this pain inflammatory or is it degenerative?
Okay, inflammatory versus degenerative.
Yeah.
And your notes give us the checklist to figure that out, right? What are the absolute must-ask questions or must-look-for signs?
Well, first, look at the pain pattern. Does it get better with rest and worse with movement? That suggests degenerative OA.
Makes sense.
Or is it actually worse at rest, maybe waking the person up at night, and it feels better with activity? That points towards inflammatory arthritis.
Okay.
Morning stiffness is another huge clue. If it's less than, say, 30 to 60 minutes, that's typical for degenerative gelling after rest.
Yeah.
But stiffness lasting over an hour, that points strongly towards inflammation.
Over an hour is key.
Definitely. Also, check for those cardinal signs of inflammation. Is the joint warm, significantly swollen, red? These are hallmarks of inflammation, usually minimal or absent in primary OA. And any systemic symptoms, fatigue, fever, they also lean towards inflammatory.
Got it. Beyond just inflammatory versus degenerative, what else about the joint involvement helps narrow things down?
The pattern of involvement is gold. Absolutely crucial. Is it just one joint? That's monoarticular. A few joints, maybe 2 to 4, oligoarticular. Right. Many joints, 5 or more. Polyarticular. Is it symmetrical, affecting the same joints on both sides of the body, like in RA often? Or is it asymmetrical? Does it hit the small joints, like fingers and toes, or the big ones, like knees and hips? And is the spine involved axial, or just the limbs peripheral? These patterns immediately point you towards certain groups of diseases listed in those differential diagnosis tables in your notes.
Right. Speaking of those tables, tables 4 and 5, what do they highlight for common presentations? Like, say, someone comes in with one hot, swollen joint.
Yeah, for acute monoarthritis, that one hot, painful joint, you must think of crystal arthritis, so gout or pseudogout, and especially septic arthritis, which is infection. Because infection is an emergency, needs urgent diagnosis and treatment.
Can't miss that one.
Absolutely not. Trauma is also on the list, of course. But for oligo or polyarthritis, acutely you might think of viral infections, but chronically you're looking at the major players.
Yeah.
RA, SLE, the spondyloarthropathies we'll talk about, chronic crystal issues. The tables lay out those likely suspects.
Your sources also include that helpful mnemonic, softer tissue.
Yeah, that's a great one. It's a way to remember the breadth of possibilities causing pain around a joint area. Sepsis, OA, fracture, tendon muscle issues, epiphyseal problems in kids, referred pain, tumor, ischemia.
Okay.
Then the big rheumatologic groups, seropositive arthrotides, seronegative arthrotides, urate, gout, or other crystals, and extraarticular things like PMR and fibromyalgia. It's just a really comprehensive mental checklist from your notes.
Very useful. Now, if there's fluid in the joint, aspirating it and analyzing that synovial fluid sounds critical from your notes.
Oh, it's often the single most important test, especially in monoarthritis. It can give you a definitive diagnosis, like infection or crystals right there. Your sources drill down on the 3 C's. Cell count and differential how many cells, what type, culture and gram stain looking for bacteria, and crystal analysis looking for gout or pseudogout crystals.
And what are the key thresholds that matter in that fluid analysis? Table 8 in your notes has details.
The WBC count, the white blood cell count, is the big one. Normal is really low, less than 200 cells. Non-inflammatory fluid, like you'd see in OA, is usually under 2,000.
Okay.
But inflammatory fluid jumps up, usually over 2,000, and often the majority are neutrophils, those first responder cells, maybe over 50%.
Yeah.
And then the septic fluid, the emergency, that's typically a really high cell count, often over 50,000, with mostly neutrophils, maybe over 75%. And finding bacteria on the gram stain or culture confirms it. Knowing those rough cutoffs is just essential.
Very clear. Your notes also touch on inflammatory markers in the blood, like CRP and ESR. What's the practical takeaway there?
Well, the main insight is that CRP, C-reactive protein, is generally a more sensitive and quicker indicator of acute inflammation than ESR, the erythrocyte sedimentation rate.
Okay, CRP is faster.
Yeah. ESR can be useful in some chronic conditions like connective tissue diseases or for tracking certain things, but it's affected by so many non-inflammatory factors, age, anemia, proteins, that a high ESR alone isn't very specific for inflammation. Your sources actually advise against using ESR as a primary screening tool for acute inflammation because of that.
Good to know. And finally, the term enthesitis comes up here. What's that?
Enthesitis is inflammation right where a tendon or ligament attaches to the bone. Your sources highlight this as a really characteristic feature of the spondyloarthropathies that group, including ankylosing spondylitis. It's a key distinguishing feature compared to rheumatoid arthritis, which mainly affects the synovium, the joint lining itself.
Okay, so inflammation at the attachment point. That whole approach, inflammatory versus degenerative, patterns, fluid analysis, markers, enthesitis, feels like a really solid framework from your notes for tackling joint pain.
It is. It helps structure the thinking process.
Now, before we dive into the specific disease categories, your sources flag several conditions as medical emergencies. It feels absolutely vital we pull these out and highlight why they're emergencies.
Absolutely critical. The first one is septic arthritis. This is infection inside the joint, usually bacterial. Your sources stress this is an emergency because it can rapidly destroy the joint cartilage, like within hours or days, and it carries a significant risk of death, maybe 10–15%.
Wow.
People with conditions like RA or diabetes or who are immunosuppressed are at higher risk. And the critical step, if you suspect it, urgent synovial fluid aspiration and analysis to look for infection, plus blood work, and you start antibiotics immediately. Time is joint, literally.
Right, so if a joint looks infected, hot, red, swollen, painful movement, don't wait. What's next on the emergency list?
Scleroderma renal crisis. This is a severe, life-threatening complication seen in scleroderma. It involves extremely high blood pressure, kind of malignant hypertension, and damage to small blood vessels in the kidney, leading to a specific type of anemia and kidney failure. The critical insight from your notes is that it needs urgent treatment, specifically with an ACE inhibitor medication. Not just any blood pressure drug. ACE inhibitors are key here.
Good to know. We'll cover scleroderma in more detail later, but knowing that potential emergency is vital. And giant cell arteritis, GCA, is flagged for a very specific, irreversible risk.
Yes, GCA. This is a vasculitis, inflammation of blood vessels affecting larger arteries, typically in people over 50. The major concern is inflammation affecting the arteries that supply the eye. This can cause sudden permanent blindness if it's not treated immediately.
Permanent blindness.
Exactly. So your sources make it crystal clear. If you suspect GCA based on symptoms like a new kind of headache, jaw pain when chewing, visual changes, you start high-dose steroids immediately. You don't wait for tests like a biopsy. You treat first to save vision.
That rapid action is critical. Okay. Finally, there's a specific warning about C-spine instability, neck instability in rheumatoid arthritis.
Yes, this is crucial if someone with long-standing RA needs any kind of procedure involving intubation, like for surgery. Chronic RA inflammation can damage ligaments in the neck, particularly around the top vertebrae, the atlantoaxial joint.
Okay.
This can lead to instability, where the bones can shift too much, subluxation. If the neck is then positioned incorrectly during intubation, there's a real risk of compressing the spinal cord. Your notes highlight this as a significant potential complication that needs careful assessment before any such procedure.
Right. So septic arthritis, scleroderma renal crisis, GCA, and RAC spine instability. These are the absolute stop and act now conditions highlighted in your source material. Good to have those front and center.
Definitely.
Okay, emergencies noted. Now let's dive into the specific disease categories, starting with the most common joint problem overall, osteoarthritis or OA.
Right. Your sources define OA as that progressive deterioration of the articular cartilage and the surrounding structures in the joint. And the key insight here, kind of moving beyond just the old wear and tear idea, is that your notes describe it as involving a complex mix of factors: genetic, metabolic, biochemical, mechanical.
So more than just wear.
Yeah, with secondary inflammation playing a role too. It's increasingly viewed as a systemic process affecting the entire joint unit, the whole organ, not just the cartilage surface wearing away.
Interesting. And who typically gets OA?
Well, it's incredibly common, especially as people age. The risk factors clearly listed in your notes are age itself, female sex, obesity, that's a big one, prior joint trauma or injury, and genetics definitely plays a part.
And what are the telltale signs and symptoms your notes describe? What does it feel like?
The classic symptom is pain that's worse with activity or use and gets better with rest. That morning stiffness we mentioned is brief, usually less than an hour, often described as gelling after sitting for a while.
Gelling. Okay.
You might feel or even hear crepitus, a grinding or crackling sensation with movement. And those bony enlargements are characteristic. Heberden's nodes on the DIP joints, the ones closest to the fingertip, and Bouchard's nodes on the PIP joints, the middle knuckle.
Right. Those bumps on the fingers.
Exactly. The sources also describe thumb squaring at the base, CMC joint, and over time, the range of motion in the affected joint gets limited.
And where does OA most commonly show up? Which joints?
Your sources list the hands, especially those DIPs, PIPs, and the base of the thumb, the hips, the knees, the first MTP joint, the base of the big toe, and the spine, particularly the neck and lower back. A useful practical tip from your notes. Involvement of the MCP joints, the main knuckles, is uncommon in primary OA. So if those are significantly affected, you think of other things like RA or maybe CPPD.
Good distinction. How do you investigate suspected OA?
Well, blood tests are typically normal things like rheumatoid factor and ANA are negative. The diagnosis is often made clinically based on the symptoms and exam and supported by x-rays. And the sources give you the 4 hallmark radiographic findings to look for on x-ray. Joint space narrowing, the cartilage thinning, subchondral sclerosis, the bone underneath hardening, subchondral cysts, little fluid pockets in the bone, and osteophytes, those bone spurs. If you happen to analyze synovial fluid, it's non-inflammatory, remember, usually less than 2,000 white cells.
Your notes emphasize that no treatment actually changes the underlying disease process, the natural history. So what's the approach then?
Right, there's no cure that reverses the damage. The core insight is symptom management and prevention. Prevention starts early, trying to avoid joint injuries, managing weight, and non-pharmacological approaches are really foundational.
Like what?
Weight loss is huge, especially for knee and hip OA. Exercise is critical. Your notes specifically call out Tai Chi as strongly recommended for hip and knee OA, backed by good evidence. Physical therapy, occupational therapy for aids and joint protection, using heat or cold, and self-management education programs.
That makes sense. And medications.
It's usually a stepped approach. Start local or with simpler systemic options first.
Sure.
So topical NSAIDs or capsaicin cream for local pain. Intra-articular steroid injections can be good for flares.
Okay.
Systemic options usually begin with acetaminophen, although its effectiveness is debated. Then oral NSAIDs, being mindful of side effects, and possibly duloxetine, an antidepressant that also helps with chronic pain. A really key takeaway from your sources is the list of treatments not generally recommended due to lack of strong evidence for efficacy. Opioids, medical cannabinoids, hyaluronic acid injections, PRP, stem cells, and the supplements chondroitin and glucosamine. That's a really important practical filter from your notes, helps avoid ineffective treatments.
That's very helpful. And surgery is an option down the line.
Right, for significant structural damage and pain impacting function, things like joint replacement surgery are options. Your notes also highlight a Cochrane review on exercise, specifically for knee OA, showing that land-based therapeutic exercise provides significant short-term relief for pain and function, with benefits lasting a few months. It just reinforces how powerful exercise can be, which is an important insight.
Absolutely. Okay, fantastic overview of OA. Now, let's shift to a group often defined, at least partly, by blood tests, the seropositive rheumatic diseases. What's the core idea here? What makes them seropositive?
The defining feature, the key insight from your sources for this group, is the presence of specific autoantibodies in the blood. Your notes dedicate a whole table to these, and knowing which antibodies are important for which disease is really crucial for diagnosis and sometimes prognosis.
Okay, let's look at a few key players from that table. Rheumatoid factor, RF. What's the story there?
Right, RF is an autoantibody, and it's positive in about 80% of patients with rheumatoid arthritis. The insight here, though, is that it's sensitive for RA, meaning it picks up a lot of cases, but it's not very specific. Meaning it can be positive in other autoimmune conditions, infections, or even in some healthy people, especially older individuals. But within RA, having a high level, a high titer, often correlates with more severe disease.
Okay, sensitive but not specific. What about anti-CCP antibodies, anti-citrullonated protein antibodies?
Now, these are much more specific for RA compared to RF. Your sources quote specificities like 94, 98%. That's high.
Wow.
And another key insight your sources highlight is that anti-CCP antibodies can appear before symptoms even start, sometimes years before, and they are strong predictors of developing erosive joint damage. So finding positive anti-CCP can be a really important early clue for RA.
Very interesting. Now, everyone's heard of ANA, anti-nuclear antibody. What's the takeaway for ANA from your notes?
ANA is an antibody directed against components of the cell nucleus. Your notes say it's very sensitive for SLE, lupus, meaning it's positive in almost all cases, so a negative test makes SLE less likely. However, it's very nonspecific.
Okay, so like RF, it can be positive in lots of other situations.
Exactly. Other autoimmune diseases, infections, certain drugs, even healthy people again. The critical choosing wisely point emphasized in your sources is don't order ANA as a general screening test without clinical suspicion of an autoimmune disease.
Right.
And another key insight, specifically for SLE, the titer, the level of ANA, doesn't track disease activity. So repeatedly checking the ANA level isn't usually helpful for monitoring lupus. That helps avoid unnecessary testing and misinterpretation.
That's really practical. What about anti-dsDNA and anti-stosum antibodies?
Okay, these two are much more specific for SLE than ANA. Anti-double-stranded DNA, dsDNA, is found in about half of SLE patients. It's highly specific, and here's the key difference. Its titer often goes up and down with disease activity, especially kidney disease and lupus, so it is a valuable monitoring tool.
Okay, dsDNA tracks activity. And anti-sulum.
Anti-Synsum or anti-Smith is less common, maybe 20–30% of SLE patients, but it's highly specific for SLE. However, unlike dsDNA, its level doesn't usually track disease activity.
Got it. Your sources list a whole alphabet soup of other antibodies: ROLA, APLA, histone, RNP, centromere, CL70, JO1, ANCAs. It seems like a lot.
It is, but knowing the key associations is really helpful. For instance, anti-Ro and anti-LA are linked to Sjogren's syndrome and also neonatal lupus. Antiphospholipid antibodies, APLA, define APS and increase clotting risk. Antihistone is often seen in drug-induced lupus. Anti-RNP is key for MCTD. Anticentromere strongly suggests limited scleroderma, CREST. Anti-CL70 points towards diffuse scleroderma and lung disease risk. Anti-Jo1 is linked to inflammatory myositis with lung disease, and ANCAs are crucial for certain types of vasculitis.
Wow.
The important insight remains that these antibodies are markers, they're key pieces of the diagnostic puzzle, but their meaning always has to be interpreted alongside the patient's symptoms and clinical picture. They're rarely diagnostic in isolation.
Makes sense. Okay, let's delve into rheumatoid arthritis, RA itself. Your notes describe it as the most common inflammatory arthritis?
That's correct. RA is a chronic systemic autoimmune disease characterized by symmetrical inflammatory synovitis, primarily affecting the peripheral joints. The underlying problem is the immune system mistakenly attacking the synovial membrane, the joint lining.
Right, the synovius.
Yeah, and this leads to the formation of that inflammatory pannus tissue we mentioned earlier, basically this angry, invasive tissue that grows over the cartilage and releases enzymes that chew up both cartilage and bone, leading to those characteristic erosions and joint destruction.
What drives that initial attack?
It's complex, a mix of genetics like that HLA-DR4-DR1 association and environmental factors. Smoking is a big environmental risk factor. These factors seem to trigger immune responses, possibly involving processes like citrullination, a modification of proteins, which can lead to the production of those highly specific anti-CCP antibodies.
Okay. What does RA typically look like clinically? How does it present?
It often starts subtly, maybe with fatigue and some joint aching, but it typically progresses to a symmetric polyarthritis. That means it affects the same joints on both sides of the body. Classically, it hits the small joints of the hands, the MCPs, knuckles, and PIPs, middle joints, and the feet, the MTPs, plus the wrists, elbows, knees, ankles, shoulders. It can even affect the cervical spine, the neck.
And the morning stiffness.
That's a hallmark. Stiffness, especially in the morning or after inactivity, lasting over an hour, and typically improving with movement or use. Profound fatigue, malaise, sometimes low-grade fever, and weight loss are common systemic symptoms too. It's not just joint pain.
The extra-articular features, the things outside the joints, seem important too, based on Table 13 in your notes.
They really highlight RA's systemic nature, yeah. Your sources list quite a few. Things like rheumatoid nodules, firm lumps under the skin, often over pressure points like the elbows, vasculitis, inflammation of blood vessels, ocular problems like dry eye mouth, secondary Sjogren's or Sicca syndrome, or more serious inflammation like episcleritis or scleritis.
Yeah.
Lung problems are common too, like interstitial lung disease or fluid around the lungs, pleural effusion, cardiac involvement, nerve problems like peripheral neuropathy, blood abnormalities like anemia or Feltes syndrome, which is RA, low white count and big spleen, and even rare kidney complications like amyloidosis.
And those joint deformities we often associate with RA.
Over time, with persistent inflammation, yes, things like swan neck and boutonniere deformities in the fingers, ulnar deviation, where the fingers drift toward the little finger side at the knuckles, and various toe deformities like claw toe or hammer toe. Chronic synovitis can also lead to complications like Baker's cyst rupture behind the knee, carpal tunnel syndrome from wrist swelling, or even tendon ruptures.
Okay. Your notes also list poor prognostic factors, things suggesting a tougher disease course.
Yeah, things like being young at onset, having high levels of RF or anti-CCP, having many actively inflamed joints early on, early evidence of erosions on X-ray, and the presence of those extra-articular features like nodules or vasculitis. These tend to predict more aggressive disease.
Got it. Investigations for RA, how do you confirm it?
Well, we discussed the key antibodies RF and especially anti-CCP. Inflammatory markers like ESR and CRP are usually elevated, reflecting the systemic inflammation. Blood counts might show anemia of chronic disease is common, or sometimes high platelets, thrombocytosis.
And imaging.
Imaging starts with plain X-rays of the hands and feet usually. You look for the key features: periarticular osteopenia, thinning bone near the joint, marginal erosions, those bites out of the bone, and joint space narrowing from cartilage loss. C-spine X-rays are important too, particularly before any surgery because of that instability risk we mentioned. Ultrasound and MRI can pick up synovitis and erosions even earlier than X-rays, which can be helpful for early diagnosis.
Okay. What's the overall treatment philosophy for RA? What are the goals?
The key insight from your notes, and this is a major shift in thinking over the last couple of decades, is the emphasis on early diagnosis and early aggressive intervention with disease-modifying anti-rheumatic drugs, or DARNs. Because there's this concept of a window of opportunity. Treating effectively early on, maybe within the first few months of symptoms, seems to really alter the long-term course of the disease, potentially preventing irreversible joint damage. The goal now is to achieve remission, or at least low disease activity. Treat-to-target strategies are common.
And what's the first-line treatment usually?
Methotrexate, MTX, is generally considered the gold standard first-line conventional DMARD, assuming there are no contraindications. It's effective and relatively inexpensive. If MTX alone isn't enough to reach the target, or if someone have those poor prognostic factors, your sources mention using combination therapy with other conventional DMARDs, like sulfasalazine or hydroxychloroquine, or moving more quickly to add more potent agents.
Like the biologics.
Exactly. Biologic DMARDs, which target specific inflammatory pathways, are used when conventional DMARDs are inadequate. Anti-TNF agents, like etanercept, infliximab, adalimumab, were the first biologics and are often the first choice among them, frequently used in combination with methotrexate.
Are there other options if anti-TNFs don't work?
Oh yes, there are other biologics targeting different molecules, like IL-6 or co-stimulation blockade, and also targeted synthetic DMARDs, like the JAK inhibitors, for example, to fositinib, which are oral medications. These provide more options for patients with refractory disease.
What about steroids and NSAIDs?
Corticosteroids are very effective for quickly reducing inflammation, so they're often used for flares or as a bridge therapy while waiting for DMARDs to start working. But the goal is always to use the lowest effective dose for the shortest time possible because of the significant long-term side effects your notes list: osteoporosis, weight gain, diabetes risk, cataracts, infections, etc. NSAIDs can help with pain and stiffness symptoms, but they don't alter the underlying disease course or prevent joint damage.
So it sounds like RA requires lifelong management.
It really does. Regular monitoring of disease activity, adjusting treatment as needed, managing complications, and screening for associated risks are all crucial. Your sources point out the increased risk of serious infections due to both the disease and treatments, osteoporosis, certain lymphomas, and importantly, cardiovascular disease. RA itself is an independent risk factor for heart attacks and strokes, contributing significantly to premature mortality. That's a vital insight. RA isn't just a joint disease, it affects the whole body.
Absolutely. Okay, moving on to another major systemic autoimmune disease, systemic lupus erythematosus, SLE. This is often seen as the quintessential multi-system disease,
It
right?
really is. SLE is a chronic autoimmune condition that can cause inflammation in pretty much any organ system. It's driven by the production of a wide range of autoantibodies and the formation of those immune complexes we talked about earlier. Your notes use the 2019 ELERAC-CAR classification criteria, Table 14, which conceptually require a positive ANA entry criterion, plus a certain score accumulated from various clinical and immunological categories.
What triggers SLE? Why does it happen?
Like RA, it's multifactorial. There's definitely a genetic predisposition. Certain HLA types, like HLA-BADR3, are associated, and perhaps defects in clearing apoptotic cells. Then environmental factors play a big role. Things like ultraviolet light exposure from the sun is a well-known trigger for flares. Smoking, certain infections, and even some medications can trigger it, or lupus-like syndromes.
Right, drug-induced lupus.
Yeah, your notes highlight drug-induced lupus, which often has specific features, is commonly associated with antihistone antibodies, and usually resolves when the offending drug is stopped. Examples listed include procainamide, hydralazine, isoniazid. Hormones also seem important, particularly estrogen, as SLE is much more common in women, especially during their reproductive years. The core problem involves defects in immune regulation, leading to that loss of self-tolerance and the production of those damaging autoantibodies and immune complexes.
Okay. What does SLE look like clinically? Your notes have a big table of potential symptoms.
It's incredibly variable from person to person and often comes in flares and remissions. Symptoms can be widespread. Systemic symptoms like fatigue, fever, weight loss are very common. Skin manifestations are classic. Photosensitivity, rash after sun exposure, the malar butterfly rash across the cheeks and nose, discoid rash, scarring, circular lesions, oral or nasal ulcers, hair loss.
Okay.
Blood issues are frequent anemia, low white blood cell counts, low platelets. Kidney disease, lupus nephritis, is a major cause of morbidity and can range from mild to severe kidney failure. Serositis, inflammation of lining tissues, causes things like pleurisy, chest pain with breathing, or pericarditis, inflammation around the heart. Musculoskeletal symptoms are common too, mainly joint pain and arthritis, which is typically non-erosive, though a Chicouther-Cromartie deformity without erosion can occur. Vascular necrosis, bone death due to poor blood supply, is also a risk, especially with steroid use.
It really affects everything.
Pretty much. Raynaud's phenomenon is common. Vasculitis can occur. And neuropsychiatric symptoms can range from headaches and cognitive dysfunction, lupus fog, to seizures, stroke, or psychosis. And just like RA, your notes point out that SLE is an independent risk factor for accelerated atherosclerosis and cardiovascular disease.
Investigations for SLE.
ANA is the highly sensitive screening test, positive in almost everyone, but remember its poor specificity. The key specific antibodies are anti-dsDNA and anti-ISIMA.
And you mentioned dsDNA and complement for monitoring.
Exactly. Your notes clarify that the anti-dsDNA titer and complement levels, C3 and C4, which are often low during active disease because they get consumed in immune complexes, are key biomarkers for monitoring SLE disease activity, especially lupus nephritis. Antiphospholipid antibodies, APLA, can also be present, increasing clotting risk and causing that false positive syphilis test, VDRL.
Okay. What are the treatment goals for SLE?
The main goals are to achieve and maintain remission or low disease activity, prevent disease flares, and minimize organ damage, while also minimizing treatment toxicity, especially from long-term steroids.
What are the cornerstone treatments?
Hydroxychloroquine is recommended for almost all SLE patients unless contraindicated. It helps control disease activity, prevents flares, and may have long-term benefits like reducing clotting risk and organ damage. It's often combined with glucocorticoids, steroids, for flares, but the goal is always to taper steroids down or off if possible.
And for more severe disease?
For moderate to severe disease or to help reduce steroid doses, immunosuppressive drugs are used. Things like mycophenolmethyl, often preferred for lupus nephritis, azathioprine, or sometimes methotrexate, especially for arthritis. Belimumab, a biologic targeting B cells, is an option for moderate refractory disease not involving severe kidney or neurological issues. Severe organ-threatening flares like severe nephritis or CNS lupus require aggressive treatment, often high-dose intravenous steroids plus cyclophosphamide or sometimes rituximab.
Lifestyle things important too.
Definitely. Sun protection is crucial because of photosensitivity. Smoking cessation is strongly advised. Vaccinations are important, though live vaccines should be used cautiously in immunosuppressed patients. And avoiding estrogen-containing contraceptives might be recommended, especially if APLA are positive.
Your notes feature the TULIP-2 trial. What was the significance there?
Yes. This trial highlighted a newer therapy, anifrolumab. It's a monoclonal antibody targeting the type I interferon receptor. The trial showed it improved clinical responses in patients with active SLE. It supports a more targeted approach by blocking type I interferons, a pathway known to be really important in driving lupus inflammation.
Interesting. Also related to antibodies, let's quickly touch on antiphospholipid antibody syndrome, APS.
Right. APS is a condition characterized by recurrent blood clots, either arterial or venous thrombosis, and/or specific pregnancy complications, like recurrent miscarriages or premature births due to placental problems. And these events occur in the presence of persistent antiphospholipid antibodies, APLA.
Can it occur on its own?
Yes, it can be primary APS occurring alone or secondary, associated with other conditions, most commonly SLE, but also other autoimmune diseases, infections, or certain drugs. There's also a rare but devastating form called catastrophic APS, involving clots forming rapidly in multiple small vessels throughout the body, which has a very high mortality rate.
How is it classified or diagnosed?
The classification criteria, Table 16 in your notes, require having at least one specific clinical event, a documented vascular thrombosis or a defined pregnancy morbidity and persistently positive APLA laboratory tests. Those lab tests are for lupus anticoagulant anticardiolipin antibodies or anti-fatty 2 glycoprotein antibodies. And the key diagnostic point from your notes is that the positive lab test needs to be confirmed on two separate occasions at least 12 weeks apart to ensure it's persistent.
Okay, persistent antibodies plus a clinical event. And treatment focuses on preventing more clots.
Exactly. For patients with a definite thrombotic event related to APS, lifelong anticoagulation, typically with warfarin, is the standard treatment to prevent recurrence. The target INR intensity might vary depending on the type of clot. For women with recurrent pregnancy loss attributed to APS, treatment during pregnancy usually involves heparin, often low molecular weight heparin, plus low-dose aspirin to improve outcomes. Catastrophic APS is a true medical emergency requiring aggressive, multi-pronged treatment, including high-dose steroids, anticoagulation, sometimes plasma exchange, or immunosuppression like cyclophosphamide.
Got it. Okay, next major category, scleroderma, also known as systemic sclerosis, SSC. The name suggests hard skin.
It does. And skin thickening and hardening is definitely a key feature, but SSC is far more than just a skin disease. It's a complex autoimmune condition characterized by sort of three core processes: damage to small blood vessels, vasculopathy, activation of the immune system with production of autoantibodies, and excessive fibrosis, that's scar tissue formation in the skin, and various internal organs.
Your sources distinguish between different forms.
Yes, primarily between localized scleroderma, like morphea or linear scleroderma, which usually just affects the skin and underlying tissues in limited areas and doesn't involve internal organs systemically, versus the generalized form systemic sclerosis. And systemic sclerosis itself is further subdivided, most commonly into limited cutaneous SSC and diffuse cutaneous SSC.
What's the difference between limited and diffuse SSC?
The main distinction is the extent of skin involvement. In limited SSC, skin thickening is typically confined to the fingers, hands, face, and forearms, lower legs, distal to elbows, knees. It often follows the pattern described by the Crest mnemonic, which isn't perfect but helpful: calcinosis, calcium deposits; Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, tight fingers; and telangiectasias, dilated capillaries. Internal organ involvement, like pulmonary hypertension, can occur but often later.
And diffuse.
In diffuse SSC, the skin thickening is more widespread, often affecting the trunk, upper arms, and thighs, proximal involvement, in addition to the distal areas. Internal organ involvement, particularly interstitial lung disease, ILD, kidney problems, heart issues, tends to occur earlier and can be more severe.
What's the fundamental process driving all this? What goes wrong?
It's thought to start with some kind of trigger leading to widespread damage to the small blood vessels, the endothelium. This causes reduced blood flow, hypoxia, and activation of the immune system. This, in turn, somehow activates fibroblasts, the cells responsible for making connective tissue, causing them to go into overdrive and produce way too much collagen and other extracellular matrix components. This excessive deposition leads to the fibrosis, the scarring and hardening of the skin and internal organs.
Okay. Your notes highlight a critical insight about mortality.
Yes, they state that lung disease, either interstitial lung disease, ILD, scarring of the lung tissue, or pulmonary arterial hypertension, PAH, high blood pressure in the lung arteries, is now the most common cause of morbidity and mortality in SSC. That's a really important point. Screening for and managing lung complications is crucial.
The classification criteria, Table 17, seem to give a lot of weight to skin thickening, especially of the fingers.
They absolutely do. A score of 9 or more is needed for definite SSC classification. And a key insight from those criteria in your notes is that definite skin thickening affecting the fingers of both hands and extending proximal to the MCP joints, the main knuckles, is sufficient on its own to score 9 points and meet the criteria. It's considered highly specific.
Wow.
Other features add points towards the classification, like puffy fingers, fingertip lesions, ulcers, or pitting scars, telangiectasias, abnormal nail fold capillaries, visible under microscopy, PAH or ILD, Raynaud's phenomenon, and the presence of SSC-related autoantibodies.
Which antibodies are important here? Which ones help distinguish the types?
There are several key ones. Anti-centromere antibodies are strongly associated with limited cutaneous SSC, the crest variant.
Yeah.
Anti-topoisomerase antibodies, also called anti-CL70, are linked to diffuse cutaneous SSC and an increased risk of developing severe ILD.
Right.
And anti-RNA polymerase III antibodies are associated with diffuse skin disease and, importantly, a higher risk of developing that emergency scleroderma renal crisis. So these antibodies can provide prognostic information too.
Okay. Beyond the skin changes, what are the major symptoms and organ involvements listed in Table 18?
Well, the skin tightening itself can be widespread, causing a mask-like facial appearance, difficulty opening the mouth, tight lips, sometimes a beak-like nose, and radial furrows around the mouth. Digital ulcers on the fingertips are common and painful. Calcinosis can occur. Telangiectasias are those little red spots, often on the face and hands.
And Raynaud.
Raynaud's phenomenon is extremely common, present in almost all patients. It involves episodic color changes in the fingers and toes, white, then blue, then red, triggered by cold or stress. Your notes say scleroderma is the most common cause of secondary Raynaud's. Raynaud's due to an underlying condition.
What about internal organs?
GI involvement is very frequent. Difficulty swallowing, dysphagia, severe heartburn, reflux, GERD, due to esophageal issues are common. The small and large bowels can also lose motility, leading to bloating, constipation, diarrhea, or bacterial overgrowth. Your notes mention wide-mouth diverticula in the colon as being pathognomonic, though rare.
And the kidneys and lungs.
Renal involvement can range from mild issues to that sudden severe scleroderma renal crisis we discussed, the hypertensive emergency. Pulmonary problems are major, ILD causing shortness of breath and cough, and PAH causing fatigue and breathlessness. Cardiac issues can include pericarditis, arrhythmias, or heart failure. MSK symptoms like joint pain, arthralgias are common, and you can even get resorption of the bone at the very tips of the fingers, acroosteolysis.
So investigations focus on screening for and assessing this organ involvement.
Exactly. Basic blood work including CBC, creatinine, and checking those specific SSC-related antibodies. Pulmonary function tests, PFTs, and high-resolution CT scans of the chest are essential to screen for and monitor ILD. Echocardiograms are used to screen for PAH. Other imaging like CXR might be used too.
Treatment sounds like it has to be tailored to the specific problems.
Precisely. There's no single cure for the underlying process, so treatment is aimed at managing symptoms and specific organ complications. Good skincare and hygiene are important. Low-dose corticosteroids might be used for inflammatory symptoms, but your notes strongly caution against doses higher than 20 milligrams of prednisone daily, as they can potentially provoke renal crisis. That's a critical point. Vascular treatments focus on Raynaud's keeping warm, stopping smoking, using vasodilator medications like calcium channel blockers. GI symptoms are managed with PPIs for reflux, antibiotics for bacterial overgrowth, prokinetic agents for motility. Renal crisis requires prompt ACE inhibitor therapy. For ILD, immunosuppression is used. Your notes highlight a key finding from a Lancet respiratory medicine trial, suggesting that mycophenolate mofetil is now often preferred over cyclophosphamide due to better long-term tolerability. PAH requires specific targeted therapies.
A very complex disease needing careful, individualized management. Okay, let's move to inflammatory myopathy, specifically polymyositis, PM, and dermatomyositis, DMM. These involve muscle problems, right?
Yes, these are autoimmune diseases characterized by inflammation in the muscles, leading to progressive symmetrical weakness, particularly in the proximal muscles, shoulders, hips, thighs, neck flexors. Patients have trouble lifting things, getting up from chairs, climbing stairs, sometimes even lifting their head off the pillow.
A crucial insight from your sources is the significant association with malignancy, especially in DMM.
Yes, that's a really important point. There's an increased risk of underlying cancer, particularly in adults diagnosed with dermatomyositis, but also with polymyositis to a lesser extent. Your notes list common associated malignancies like breast, lung, colon, and ovarian cancers.
Are there risk factors that increase the likelihood of the myositis being cancer-related?
Yes, things like older age at onset, over 50, having dermatomyositis specifically, very high levels of muscle enzymes like CK at diagnosis, and sometimes the myositis symptoms peaking around the same time the cancer is found. Cancer screening is therefore an important part of the initial workup, especially in adults with new onset DMM or PM with risk factors.
Your notes mention a difference in the underlying pathology between PM and DMM.
Briefly, yes. In polymyositis, the inflammation, mainly T cells, seems to directly attack within the muscle fibers and endomysial infiltrate. In dermatomyositis, the inflammation is thought to be primarily mediated by complement activation, targeting small blood vessels around the muscle bundles, perivascular infiltrates, leading to muscle damage concentrated around the edges of the fascicles, perivascular atrophy.
And dermatomyositis has those very distinct skin features that PM
Yeah,
lacks.
absolutely. And they can be incredibly helpful diagnostically, sometimes appearing before significant muscle weakness. Your notes describe Gottron's papules, these pinkish violaceous, sometimes scaly bumps over the knuckles and finger joints, and Gottron's sign, which is similar redness over elbows, knees, or ankles. These are considered pathognomonic, meaning they're pretty much diagnostic if present.
Okay. What else?
The heliotrope rash, a purplish rash around the eyelids, sometimes with swelling, is also very characteristic. The shawl sign is a rash across the upper back and shoulders, like where a shawl would sit. Mechanics' hands refer to roughened, cracked skin on the palms and sides of the fingers, resembling a manual laborer's hands. And redness or abnormal capillaries around the fingernails, periungual erythema, can also be seen.
What about symptoms beyond muscle weakness and skin rashes?
Well, muscle pain, myalgia might be present, but weakness is usually the dominant symptom. Involvement can also affect the esophagus, leading to difficulty swallowing, dysphagia, which can increase aspiration risk. Lung involvement is also significant. Interstitial lung disease, ILD, can occur, sometimes associated with specific antibodies like anti-Jo1, and respiratory muscle weakness can lead to breathing problems. Cardiac involvement can also happen.
Investigations. What confirms the diagnosis?
Muscle enzymes, particularly creatine kinase, CK, are typically markedly elevated, indicating muscle damage. Inflammatory markers like ESR-CRP may be elevated. ANA can be positive. Testing for specific myositis-associated antibodies is important, like anti-Jo1, anti-MI2, anti-SRP, as they can correlate with clinical features and prognosis.
Imaging. Biopsy.
MRI of the muscles can show inflammation, edema. EMG, electromyography, shows characteristic changes of myopathy. But a muscle biopsy is often needed to confirm the diagnosis, show the inflammation, and help distinguish PM from DMM or other muscle diseases. And again, age-appropriate cancer screening is important.
And treatment.
High-dose corticosteroids, like prednisone, are the initial mainstay of treatment to quickly reduce inflammation and improve strength. These are usually tapered slowly over months. Immunosuppressive drugs, like azathioprine or methotrexate, are often added early on, both to help control the disease and to allow for lower steroid doses, steroid-sparing effect. For severe or refractory disease, intravenous immunoglobulin, IVIG, can be effective. Hydroxychloroquine might help specifically with the skin rash in DMM. Physical therapy is also crucial to maintain function and prevent contractures.
Okay. Next up, Sjogren's syndrome, SS. This is primarily known for dryness, right? But your notes suggest it's more than just that.
Much more, potentially. It's an autoimmune disease where the immune system primarily attacks the moisture-producing glands, the lacrimal glands, tear production, and salivary glands, saliva production. This leads to the characteristic symptoms of dry eyes, keratoconjunctivitis, sicca, or xerophthalmia, and dry mouth, xerostomia. But in a significant minority, maybe 20% or so, it becomes a systemic disease affecting other organs.
And a key insight from your sources is a potential serious complication.
Yes, patients with Sjogren's syndrome have a significantly increased risk. Your notes quote, a 6-7% lifetime risk of developing non-Hodgkin's lymphoma, particularly Molt lymphoma, originating in the salivary glands. This requires ongoing vigilance.
Your notes distinguish primary versus secondary SS.
Right. Primary Sjogren's occurs on its own. Secondary Sjogren's develops in the context of another established autoimmune disease, most commonly rheumatoid arthritis, but also SLE or scleroderma. It's much more common in women, often with onset in middle age, 40s, 60s.
How is it classified or diagnosed? Tail 19.
The classification criteria use a scoring system based on objective evidence. You need a score of 4 or more. Points are given for things like having a positive salivary gland biopsy, showing characteristic lymphocytic infiltration, focal lymphocytic ceolidinitis, having positive anti-SSRO antibodies, a key immunological marker, objective signs of significant eye dryness based on ocular staining scores, abnormal Schirmer's test results, measuring tear production, or reduced unstimulated salivary flow rate.
So what are the common symptoms?
The sicca complex, dry eyes and dry mouth, dominates for many. Dry eyes feel gritty, burning, itchy, sensitive to light. Dry mouth makes it hard to swallow dry food, speak for long periods, increases risk of dental caries, cavities, and oral candidiasis, thrush. Patients might also have dryness elsewhere, like skin or vaginal dryness. Swelling of the parotid glands can occur.
And the extraglandular systemic symptoms.
These can include fatigue, often profound, low-grade fever, thyroid dysfunction, autoimmune thyroiditis is common, joint pain, arthralgias, or even inflammatory arthritis, usually non-erosive if it's primary SS, but can be erosive if secondary to RA. Interstitial lung disease, kidney problems like interstitial nephritis or glomerulonephritis, vasculitis affecting the skin or nerves, peripheral neuropathy, and that increased risk of lymphoma we mentioned. Your sources mentioned the classic triad often associated with Sjögren's: dry eyes, dry mouth, and arthritis.
Treatment focuses mainly on the dryness.
For many patients, yes. Managing the sicca symptoms is key to comfort and preventing complications. This involves using artificial tears frequently, lubricating eye gels or ointments at night, sometimes procedures like punctal occlusion to keep tears around longer. For dry mouth, meticulous oral hygiene is vital. Frequent sips of water, sugar-free candies, or gum to stimulate saliva, saliva substitutes, and prescription medications like pilocarpine or cevimeline can stimulate saliva production. Antifungals are needed for oral candidiasis.
And for systemic symptoms.
Treatment is guided by which organs are involved, similar to other systemic autoimmune diseases. Hydroxychloroquine might be used for joint pain and fatigue. Other immunosuppressants might be needed for significant organ involvement, like lung or kidney disease. And regular monitoring for lymphoma is important.
Okay. And finally, in the seropositive connective tissue disease section, your notes briefly mention mixed connective tissue disease, MCTD, and overlap syndrome.
Right. These terms describe situations where patients have features that seem to fit into several different connective tissue diseases simultaneously. MCTD specifically refers to a syndrome that often starts with Raynaud's phenomenon and swollen, puffy fingers, and goes on to develop features overlapping SLE, scleroderma, and polymyositis.
Is there a key marker for MCTD?
Yes, the diagnostic hallmark of MCTD is the presence of high titers of a specific autoantibody called anti-U1RNP, ribonuclear protein. Overlap syndrome is a broader term used when a patient clearly meets criteria for two or more distinct connective tissue diseases. For example, someone with definite RA and definite SLE.
Prognosis for MCTD.
It's variable. Some patients remain stable for years, some evolve into a more defined CTD like scleroderma or SLE, and some develop severe complications. Your notes contain another critical insight for MCTD. Pulmonary arterial hypertension, PAH, is a major cause of death in MCTD patients, making screening for PAH really important in this group as well. Treatment for MCTD and overlap syndromes is generally guided by the specific symptoms and organ systems involved, mirroring the treatments for the individual diseases whose features are present.
That's a really comprehensive look at that whole group, often characterized by autoantibodies. It really shows how these markers are key clues, but the clinical picture drives the diagnosis and management.
Absolutely. The antibodies help categorize, but the patient's presentation is paramount.
Okay, let's shift gears now to the seronegative rheumatic diseases, also known as the spondyloarthropathies. What distinguishes this group? What makes them seronegative compared to the last set we discussed?
Well, the core distinction, as the name suggests and is highlighted in your comparison table, table 24, is that these conditions are typically negative for rheumatoid factor, RF, and antinuclear antibodies, ANA. That's the seronegative part.
Okay, no RF for ANA usually. What do they have in common?
They share a cluster of common features. First, a tendency to involve the axial skeleton, the spine, and sacroiliac joints, causing sacroiliitis and spondylitis. Second, peripheral arthritis, which is often asymmetrical, not the same joints on both sides, tends to affect larger joints and often favors the lower extremities. Third, enthesitis, that inflammation where tendons and ligaments attach to bone, is a hallmark feature. Fourth, dactylitis, which is inflammation of a whole finger or toe, making it look like a sausage. Sausage did it.
Okay, axial, asymmetric, peripheral, enthesitis, dactylitis.
Right, and they also share certain extra-articular features, like inflammatory eye disease, uveitis, inflammatory bowel disease, IBD, and characteristic skin rashes like psoriasis. And finally, there's a strong genetic association with the HLA-B27 gene, although not everyone with these conditions is HLA-B27 positive, and most people with HLA-B27 don't get the diseases. But that combination of features really defines the group.
Got it. The prototypical spondyloarthropathy, the classic example, is ankylosing spondylitis.
AS. Yes, AS is the classic one. It's a chronic inflammatory arthritis primarily affecting the sacroiliac joints and the vertebrae of the spine. Enthesitis is a major pathological feature, leading to inflammation where ligaments and tendons attach to the vertebrae. Over time, this inflammation can lead to erosion and then reactive bone formation, eventually causing ossification bone bridges called syndesmophytes forming between vertebrae, potentially leading to fusion of the spine.
How is AS diagnosed or classified?
The ASS classification criteria are commonly used. They're based on a combination of symptoms, imaging, and HLA-B27 status. Basically, you need to have chronic inflammatory back pain, starting before age 45, lasting over 3 months, plus either imaging evidence of sacroiliitis on X-ray or MRI, plus at least one other spondyloarthritis feature, or you need to be HLA-B27 positive, plus have at least 2 other spondyloarthritis features.
What are those key spondyloarthritis features?
Things like the inflammatory back pain itself, arthritis, especially peripheral, enthesitis, heel pain is common, uveitis, eye inflammation, dactylitis psoriasis, Crohn's disease, or ulcerative colitis, a good responsive symptoms to NSAIDs, a family history of spondyloarthritis being HLA-B27 positive, and having an elevated CRP.
Your notes compare inflammatory back pain to mechanical back pain in Table 26. That seems really important.
It is because they have very different characteristics. Inflammatory back pain typically has an insidious onset, starts younger, under 45, is often worse at night or with rest. Patients might have to get up and move around, improves with exercise or activity, and is associated with significant morning stiffness. Mechanical back pain is often related to activity or injury, can occur at any age, usually feels better with rest, and morning stiffness is less prominent. Recognizing inflammatory back pain is key to suspecting AS.
Who gets AS, and what are the classic signs beyond the back pain?
It's historically considered more common and often more severe in men, typically starting in the late teens or 20s. A very high percentage, maybe 90–95% of white patients with AS are HLA-B27 positive. Your notes mention a rule of 2s for HLA-B27 risk. 20% of B27 positive individuals develop some spondyloarthropathy feature, but only 2% develop classic AS. So B27 is a risk factor, not destiny.
Okay. Symptoms beyond the back.
Chronic, mid, or lower back stiffness and pain, often radiating to the buttocks. Alternating buttock pain is characteristic of sacroiliitis. Over time, spinal mobility becomes restricted. You can measure decreased range of motion using tests like the Schober test for lumbar flexion, measuring chest expansion or cervical rotation. Posture can change significantly with loss of the normal lumbar curve, increased thoracic kyphosis, hunching, and increased neck flexion, leading to difficulty looking straight ahead. Your notes mention measuring the increased occiput to wall distance. The classic late-stage X-ray finding is the bamboo spine, where the spine looks fused.
What about peripheral symptoms in AS?
The peripheral arthritis can occur, typically asymmetrical, affecting larger joints like the hips, knees, or shoulders, often in the lower limbs. Enthesitis is common, causing pain at sites like the Achilles tendon insertion or the plantar fascia insertion. Heel pain. Dactylitis can also occur.
And those extra-articular features, there's a mnemonic for AS too, right? The 6As.
Yes, the 6A's mnemonic from your notes covers the main ones. Atlantoaxial subluxation, that potential C1, C2 instability in the neck, important for intubation risk again. Anterior uveitis, inflammation of the front part of the eye causing pain, redness, light sensitivity, this is quite common.
Yeah.
Apical lung fibrosis, scarring at the tops of the lungs, relatively rare. Aortic incompetence, leakage of the aortic valve, rare.
Yeah.
Amyloidosis, a rare protein deposition complication. And autoimmune bowel disease, association with Crohn's and UC. Again, these aren't always present, but they are recognized associations.
Investigations for AS.
X-rays of the sacroiliac joints are key, looking for changes like blurring of the joint margins, sclerosis, increased bone density, erosions, and eventually fusion or ankylosis. Spinal X-rays can show squaring of the vertebral bodies, shiny corners, inflammation at the edges, syndesmophytes, those bony bridges, and ultimately the bamboo spine. MRI is more sensitive for detecting early inflammation, bone marrow edema, in the SI joints and spine, especially using stir sequences. Labs often show elevated ESR-CRP during active inflammation, and HLA-B27 testing is usually done. Disease activity scores like the BAST-AI are used to monitor symptoms.
Treatment for AS, what's the approach?
Non-pharmacological approaches are absolutely critical. Regular exercise, especially focusing on posture, spinal mobility, and stretching, is vital to maintain function. Physical therapy plays a big role. Breathing exercises can help maintain chest expansion. Smoking cessation is important too.
And medication.
NSAIDs are the first-line medication for both axial spine and peripheral pain and stiffness. Many patients respond well. If NSAIDs aren't enough, or for specific issues like peripheral arthritis flares, local steroid injections can be used. Conventional DMARDs like sulfasalazine or methotrexate are generally only effective for the peripheral arthritis symptoms, not the axial spinal disease.
Hmm.
It's the key difference from RA.
So what do you use for the spine if NSAIDs fail?
That's where the biologics come in. For patients with active axial disease that hasn't responded adequately to NSAIDs, or for refractory peripheral arthritis, biologic agents are recommended. Anti-TNF inhibitors were the first and are highly effective. More recently, inhibitors of IL-17 have also proven very effective for NS. These can significantly reduce symptoms and inflammation.
Prognosis. How do people do long term?
It's variable. Many patients can manage their symptoms well with exercise and medication, although some degree of spinal stiffness or fusion might develop over time. Remissions and relapses are common. Factors suggesting a potentially worse prognosis include early onset, early hip involvement, and persistent high inflammation.
Okay, clear picture of AS. Now, enteropathic arthritis, EA, is another spondyloarthropathy, but this one is linked to something seemingly unrelated. Inflammatory bowel disease, IBD.
Exactly. Enteropathic arthritis refers to the arthritis and other musculoskeletal problems like peripheral arthritis, spondylitis, and enthesitis that occur in people who have ulcerative colitis UC or Crohn's disease.
Your notes compare the axial, spinal, and peripheral arthritis seen in EA, Table 27. How do they differ?
They often behave quite differently. The spondylitis associated with IBD looks and acts very much like AS. It's often HLA-B27 positive, more common in men, can actually start before the bowel symptoms appear. And importantly, its activity level often runs independent of the IBD activity. The spine can flare even when the gut is quiet.
Okay, spine acts like AS. What about the peripheral arthritis in EA?
The peripheral arthritis is usually different. It tends to be asymmetrical, often affecting large joints, particularly in the lower limbs. It affects men and women about equally. It typically starts after the IBD diagnosis is made. And crucially, its activity often parallels the activity of the underlying IBD. If the bowel disease flares up, the peripheral joints tend to flare up too, and treating the IBD often helps the joints.
That parallel course is interesting. Any treatment considerations specific to EA?
Yes, a key point from your notes is that NSAIDs need to be used cautiously in patients with IBD, as they can potentially trigger flares of the bowel disease in some individuals. So you have to weigh the risks and benefits carefully. Treatments often focus on therapies that treat both the joints and the gut, like sulfasalazine or biologic agents, particularly TNF inhibitors, which are effective for both IBD and the associated arthritis.
Makes sense. Psoriatic arthritis, PSA, is also in this group, linking joints and skin disease, psoriasis.
Right. PSA is an inflammatory arthritis that occurs in people who have psoriasis, that chronic skin condition causing red scaly patches. Interestingly, your notes mention that the joint disease can actually show up before the skin lesions in a significant minority of cases, maybe 15–20%. So you can have PSA without visible psoriasis initially.
What are the common patterns of joint involvement in PSA? It seems quite varied.
It is quite varied. Your notes list 5 main patterns. The most common pattern seen in maybe 70% is an asymmetric oligoarthritis, affecting just a few joints, often in the lower limbs. Another classic pattern involves the DIP joints, the joints closest to the fingertips, often associated with psoriatic nail changes.
Nail changes.
Yes. Psoriatic nail involvement is common in PSA and a helpful clue. Things like nail pitting, little dents, onycholysis, nail lifting off the bed, or oil drop discoloration under the nail.
Okay, other patterns.
PSA can also present as a symmetric polyarthritis that looks very similar to rheumatoid arthritis, making differentiation important, checking RFCCP hubs, as they're usually negative in PSA. Axial disease involving the sacroiliac joints and spine, similar to AS, can also occur. And finally, there's a rare but severe deforming pattern called arthritis mutilans, causing significant bone destruction and joint collapse, often in the hands and feet, telescoping digits.
And PSA also has those other spondyloarthritis features.
Yes, dactylitis, sausage digit, and enthesopathy, inflammation at tendon ligament insertions, are common and characteristic features of PSA. Morning stiffness is usually present, typically lasting over 30 minutes. Eye inflammation, conjunctivitis, arabitis can occur too.
How is PSA classified, Table 28? Those Caspar criteria.
Yes, the Caspar criteria are widely used for classification. To meet them, a patient needs to have evidence of inflammatory articular disease, arthritis, spondylitis, or enthesitis, plus at least 3 points accumulated from 5 categories. Those categories are 1. Evidence of current psoriasis, a past history or family history. 2. Presence of psoriatic nail dystrophy. 3. A negative test for rheumatoid factor. 4. Presence of current dactylitis or a history of it. 5. Radiologic evidence of new bone formation near joints on hand-foot x-rays, excluding osteophytes.
Okay. What about treatment for PSA?
Well, managing the skin psoriasis is often part of the overall plan. For the joints, NSAIDs and local steroid injections can help with symptoms, but like in AS, they don't stop disease progression. Conventional DMARDs like methotrexate, sulfasalazine, or leflunomide are important, especially for peripheral arthritis, and should be started early to minimize joint damage.
And biologics.
Biologics have really revolutionized PSA treatment, especially for patients who don't respond well to conventional DRRs or those with significant axial disease or enthesitis. Anti-TNF inhibitors are very effective for both skin and joints. More recently, biologics targeting IL-17 or the IL-12/23 pathway have also shown excellent results in PSA. The choice often depends on the specific pattern of disease and patient factors.
Got it. Finally, in this seronegative group, reactive arthritis, RE.
Right. Reactive arthritis is defined as an arthritis, usually peripheral, that develops shortly after an infection elsewhere in the body, typically in the gastrointestinal GI or genitory G tract. It's important to understand it's not the infection in the joint itself that would be septic arthritis, but rather an immune reaction triggered by the infection elsewhere. The arthritis typically lasts for at least a month.
What kinds of infections typically trigger REAA?
Your sources list several common culprits. For GI infections, bacteria like Shigella, Salmonella, Campylobacter, Yersinia, and even C. difficile. For GU infections, the most common trigger is Chlamydia trachomatis, but mycoplasma can also be involved.
What are the symptoms of reactive arthritis?
The main musculoskeletal symptom is usually an acute onset asymmetric arthritis, often affecting one or just a few joints, typically in the lower limbs, knees, ankles. Axial involvement, spondylitis or sacroiliitis, can occur, especially in HLA-B27 positive individuals. Enthesitis, heel pain, is common, and dactylitis, sausage toes, are also characteristic features.
And extraarticular features are common too.
Yes, very common and part of the classic picture. Eye inflammation, particularly conjunctivitis, often mild, but sometimes more serious, anterior uveitis. Characteristic skin lesions can occur, like keratoderma blennoragicum, waxy scaling rash, often on the palms and soles, and balanitis cercinata, painless rash on the glans penis. Your sources call this diagnostic when present. Painless oral ulcers are also seen sometimes. And GU symptoms like urethritis, inflammation of the urethra, or cervicitis, sometimes with sterile pyuria, white cells in urine without bacteria.
There's that memorable mnemonic for the triad.
Yes, the classic triad. Can't see, can't pee, can't climb a tree, referring to conjunctivitis, urethritis, and arthritis. Your sources note this triad is highly specific for RAA when present, but it's only seen in maybe half the cases or less. You can definitely have RAA without all three.
How do you investigate suspected RAA?
It's largely a clinical diagnosis based on the pattern of symptoms following a relevant infection. But you try to find evidence of the preceding infection if possible. Stool cultures, tests for chlamydia from GU swabs or urine. However, these tests might be negative by the time the arthritis appears.
Okay.
Serological tests might show HLA-B27 positivity, present in about half of cases, associated with more severe chronic disease, and elevated ESR-CRP. Joint fluid aspiration is important mainly to rule out septic arthritis and RAA. The joint fluid will be inflammatory but sterile. No bacteria on culture.
Treatment and prognosis for RAA.
First, you treat the underlying infection if it's still present. Example, antibiotics for chlamydia. For the arthritis itself, NSAIDs are the first-line treatment. Physical therapy and exercise are important. Local therapies like intra-articular steroid injections can help affected joints. For persistent or severe arthritis, systemic corticosteroids or conventional DMARDs like sulfasalazine or methotrexate might be needed, particularly for peripheral symptoms. TNF inhibitors might be considered for refractory spinal disease.
Does it usually go away?
Most cases of RA are self-limited, resolving within 3 to 5 months, maybe up to a year. However, chronic or recurrent symptoms can persist in a minority of patients, maybe 15–20%, particularly those who are HLA-B27 positive or have hip involvement.
Okay, that covers the spondyloarthropathies. The pattern of axial involvement, asymmetrical peripheral arthritis, enthesitis, dactylitis, often with those extra-articular features, and the HLA-B27 link really sets them apart as a group.
Definitely. Recognizing that cluster of features is key.
Let's talk about crystal-induced arthropathies now. Gout and pseudogout. Both cause acute, painful joint inflammation because of crystals, but they're distinct conditions, and your notes highlight the key differences in Table 29.
Yes, they are often confused clinically because they can both present as a sudden, painful, swollen joint. But the underlying crystals, the common locations, and the long-term implications are different. Getting the diagnosis right is crucial because the treatments differ significantly, especially long-term.
So what are the crystals?
Gout is caused by the deposition of monosodium urate, MSU, crystals. Pseudogout, the more formal name is calcium pyrophosphate dehydrate, CPPD deposition disease, is caused by CPPD crystals.
And the crucial diagnostic insight comes from looking at joint fluid under the microscope.
Absolutely. Synovial fluid analysis with polarized light microscopy is the gold standard for diagnosis. Gout, MSU crystals, are typically needle-shaped and show strong negative birefringence, meaning they appear yellow when aligned parallel to the slow axis of the compensator. CPD-PD crystals, on the other hand, are usually rhomboid-shaped, like little rectangles or squares, and show weak positive birefringence appearing blue when parallel. Seeing those characteristic crystals confirms the diagnosis.
Okay, needles versus rhomboids, yellow versus blue. What about where they typically show up, common locations?
Gout has a real predilection for the first MTP joint, the base of the big toe. That classic presentation is called podagra, but also commonly affects the midfoot, ankle, and knee, generally favoring the lower extremities, especially early on. CPPD most commonly affects the knee, followed by the wrist, shoulder, ankle, elbow, and MCP joints, the knuckles.
And radiographic differences.
Chronic untreated gout can lead to characteristic bone erosions on X-ray. They often look like punched-out lesions with overhanging edges, sometimes associated with soft tissue masses called tophi. CPPD, conversely, is associated with chondrocalcinosis, that's calcification within the cartilage, hyaline or fibrocartilage, which appears as fine linear radiodensities on X-ray, particularly in the knees, wrists, TFCC, and pubic symphysis.
Okay, let's focus on gout first. It's all about uric acid, right?
Correct. Gout is fundamentally a disorder of purine metabolism that leads to hyperuricemia, too much uric acid in the blood. Uric acid is the end product of purine breakdown. Purines come from diet and breakdown of our own cells. If you produce too much uric acid, or more commonly, if your kidneys don't excrete enough of it, the levels rise. When the concentration gets too high, it can crystallize out as MSU in joints and other tissues.
What causes that hyperuricemia? What are the risk factors?
There are non-modifiable factors like genetics. Some people are just predisposed to underexcrete or overproduce uric acid, male sex, increasing age, and certain ethnicities. But the modifiable risk factors are really key takeaways from your notes. Diet plays a big role. High intake of purine-rich foods like organ meats, liver, kidney, some seafood, sardines, shellfish, red meat. Alcohol, especially beer and spirits, significantly increases risk. High fructose corn syrup found in sugary drinks is another major culprit.
Okay, diet is big. What else?
Dehydration, conditions that impair kidney function, renal failure, metabolic syndrome, obesity, high blood pressure, high cholesterol, insulin resistance, and several common medications are well-known triggers. Your notes give you helpful mnemonics. Fex-T for drugs, furosemide and other loop diuretics, aspirin, low dose paradoxically raises uric acid, cyclosporine, immunosuppressant, and thiazide diuretics. And salt for foods, seafood, alcohol, liver, kidney, turkey meat. Remembering those helps identify potential triggers.
Very useful. What does an acute gout attack feel like?
It's typically characterized by a sudden onset of excruciating pain, usually in a single joint, often waking the person from sleep. The joint becomes intensely inflamed, red, hot, swollen, and exquisitely tender to even light touch. Limited mobility is profound due to pain. Usually peaks within 12-24 hours and then gradually subsides over days to weeks, even without treatment, but it tends to recur.
Your notes mention it can mimic cellulitis.
Yes, the intense redness and swelling can look like a skin infection, cellulitis, but a key difference is that in gout, movement of the joint itself is usually extremely painful and restricted, whereas in cellulitis, the pain might be more superficial and passive joint movement might be less painful. Differentiating is critical because the treatments are obviously very different.
And tophi, what are those?
Tophi are chronic accumulations of MSU crystals that deposit in and around joints, in cartilage like on the ear helix, tendons like the Achilles, bursae like over the elbow, olecranon bursora, or just under the skin. They appear as firm, non-tender lumps, sometimes with a whitish chalky material visible underneath thin skin. Their presence indicates chronic, often undertreated gout. Chronic gout can also cause kidney problems like gouty nephropathy or uric acid kidney stones.
How do you diagnose and treat gout definitively?
As we said, the definitive diagnosis is identifying those needle-shaped, negatively birefringent MSU crystals in synovial fluid aspirated from an affected joint during a flare. That's the gold standard. Blood uric acid levels are usually elevated at some point, but they can actually be normal or even low during an acute flare due to inflammatory effects. So a normal level doesn't rule out gout during an attack. X-rays are often normal early on, but show those characteristic erosions and tophi in chronic disease. Ultrasound is increasingly used and can show findings like the double contour sign, urate crystals coating the cartilage surface.
Okay. And treatment. It sounds like there are two distinct goals: treating the acute flare and long-term prevention.
It's exactly. Treatment for the acute attack aims to relieve the intense pain and inflammation as quickly as possible. The main options listed in your notes are high-dose NSAIDs, corticosteroids given orally, injected into the joint, or sometimes intravenously, or colchicine, which works best if started very early in the flare within 12-24 hours, using specific dosing regimens outlined in your notes. The choice depends on the patient's comorbidities, the severity of the attack, and contraindications.
And the long-term management. Preventing future attacks.
This is all about lowering the body's overall uric acid level using urate-lowering therapy, ULT. Conservative measures are important first steps. Dietary modifications, avoiding those high-puring foods, sugary drinks, excessive alcohol, ensuring good hydration, weight loss if overweight, and reviewing medications to stop any unnecessary hyperuricemic drugs if possible.
But often medication is needed.
Yes, for most patients with established gout, medical ULT is necessary to prevent recurrent flares and long-term complications like tophi and joint damage. Your notes highlight the 2020 American College of Rheumatology ACR guideline recommendations here. Allopurinol, a xanthine oxidase inhibitor, it blocks uric acid production, is recommended as the preferred first-line ULT for all patients, including those with chronic kidney disease, starting at a low dose and titrating up. Febuxostat is another xanthine oxidase inhibitor, usually considered second line, perhaps if allopurinol isn't tolerated or effective. But your notes mentioned exercising caution with febuxostat in patients with established cardiovascular disease due to trial data showing a potential increased risk. Uricosuric agents, like probenecid, which increase kidney excretion of uric acid, are rarely used now.
When should ULT be started?
Key indications listed in your notes for starting ULT include having 2 or more gout flares per year, the presence of 1 or more tophi, or evidence of radiographic damage attributable to gout.
And there's a point about starting prophylaxis.
Yes, a crucial practical insight from the guidelines emphasized in your notes. When initiating ULT, like allopurinol, it's strongly recommended to also start concurrent prophylactic anti-inflammatory therapy, usually low-dose colchicine or a low-dose NSAI for at least 3 to 6 months. This is because rapidly lowering uric acid levels can paradoxically trigger gout flares early in treatment, and the prophylaxis helps prevent this. The overall goal of ULT is to lower the serum urate level to below 6 mg/dL, or sometimes below 5 mg/dL if tophi are present, to dissolve existing crystals and prevent new ones from forming.
That's very clear on gout. Now what about pseudogout, CPPD?
Right, CPPD disease. This involves inflammation triggered by those calcium pyrophosphate dihydrate crystals. The underlying pathology involves phagocytosis of these crystals by neutrophils in the joint, leading to an inflammatory response. Flares are often acute, causing pain, swelling, and redness, similar to gout, but perhaps often a bit slower in onset and less intensely painful than the worst gout attacks. Like gout flares, they are usually self-limited over days to weeks. It's often monoarticular, but can certainly affect multiple joints.
What are the risk factors for CKPD? Who gets it?
Incorrecting age is the biggest risk factor. It's much more common in older adults. It's also associated with underlying joint damage, like advanced OA or neuropathic joints, Charcot joints. And importantly, it can be associated with certain metabolic conditions, so your notes mention checking for things like hyperparathyroidism, too much parathyroid hormone affecting calcium, hypothyroidism, underactive thyroid, hemochromatosis, iron overload, and hypomagnesemia, low magnesium. Acute flares can often be triggered by intercurrent illness, surgery, or trauma.
Symptoms. Which joints?
As mentioned, it most commonly affects the knees, wrists, MCP joints, hips, shoulders, and ankles. It can present in several ways. 1. Asymptomatic crystal deposition, where chondrocalcinosis is just seen incidentally on an X-ray without symptoms. 2. Acute CPPD crystal arthritis, those recurrent flares mimicking gout. This is what's often called pseudogout. 3. Chronic CPPD crystal inflammatory arthritis, which can mimic rheumatoid arthritis, causing persistent inflammation of multiple joints. 4. Sometimes associated with a severe degenerative arthropathy, particularly in the knees, wrists, or shoulders.
Diagnosis relies on finding the crystals again.
Yes, definitive diagnosis requires joint aspiration and finding those weakly, positively birefringent rhomboid-shaped CPPD crystals in the synovial fluid. X-rays showing chondrocalcinosis strongly support the diagnosis, but you can have flares without visible chondrocalcinosis, and chondrocalcinosis can be present without causing symptoms.
And treatment for CPPD. Is it different from gout?
Yes, significantly different, especially long-term. For acute flares, the treatment is similar to gout flares. Joint aspiration, which can be therapeutic itself by removing crystals. Intra-articular steroid injection is often very effective. Cool packs, rest. Oral NSAIDs or systemic corticosteroids can also be used if needed.
What about long-term treatment? Is there a ULT equivalent?
This is the key difference. Unlike gout, there is currently no effective treatment that removes CPPD crystals or prevents their formation, no disease-modifying treatment for the underlying crystal deposition process. Your notes, referencing the European League Against Rheumatism, ELA recommendations, emphasize this point and also state that no treatment is needed for asymptomatic chondrocalcinosis found incidentally on X-ray. Chronic management might involve using NSAIDs intermittently for symptoms or sometimes low-dose prophylactic colchicine, but its effectiveness in preventing CPD flares is considered controversial and less established than in gout. Management mainly focuses on treating the acute flares when they happen and managing any associated osteoarthritis.
So, two very different crystal diseases. Gout involves urate, has clear risk factors and triggers, specific erosive changes, and effective long-term urate-lowering therapy. Pseudogout involves CPPD, is linked to age and metabolic conditions associated with chondrocalcinosis, but lacks a specific long-term therapy beyond managing flares. Getting that crystal analysis from joint fluid is absolutely key to tell them apart.
Exactly. That fluid analysis is often the most critical step.
Okay, our final major category from your notes, non-articular rheumatism. This seems to cover conditions causing pain and stiffness, but where the problem isn't originating from inflammation or damage within the joint synovium or cartilage itself.
That's right. This category includes disorders affecting the soft tissues around the joints, things like bursitis, inflammation of a bursa sac, tendinitis, inflammation of a tendon, or tenosynovitis, inflammation of a tendon sheath. But it also includes more widespread conditions causing musculoskeletal pain and stiffness, like fibromyalgia and polymyalgia rheumatica, PMR.
Let's start with polymyalgia rheumatica, PMR. What defines this condition?
PMR is an inflammatory condition, primarily characterized by significant pain and stiffness, particularly in the proximal muscle groups, specifically the shoulder girdle and the hip girdle. A really key insight from your notes is its close relationship with giant cell arteritis, GCA, that emergency vasculitis we talked about earlier. About 15% of people diagnosed with PMR will eventually develop GCA, and conversely, up to half of patients diagnosed with GCA also have symptoms of PMR. So you always need to think about GCA in someone with PMR symptoms.
Okay, linked to GCA. And you mentioned stiffness, but not weakness.
Correct. Despite the muscle pain and stiffness, which can be quite disabling, there is no true muscle weakness on objective testing in PMR. Patients might feel weak because of the pain and stiffness, but their actual muscle strength is normal. That helps distinguish it from inflammatory myopathies like PMDMM, where weakness is the key feature.
What are the defining features for classification? Table 30.
The classification criteria require the patient to be over 50 years old, have bilateral shoulder aching, and have abnormal inflammatory markers, elevated ESR and/or CRP. Additional points are then added for things like morning stiffness lasting longer than 45 minutes, hip pain or limited hip motion, the absence of rheumatoid factor or anti-CCP antibodies, helping rule out RA, and the absence of other joint involvement. Specific ultrasound findings, like bursitis in the shoulders or hips, can also contribute points. A score of 4 or more, or 5 or more if using ultrasound, supports the classification. A prompt, dramatic response to low-dose corticosteroids is also considered a hallmark feature, although not part of the formal criteria.
So symptoms often include that prominent stiffness.
Yes, the pain and stiffness are typically symmetrical and affect the neck, shoulders, upper arms, hips, and thighs. The gel phenomenon, stiffness, after periods of rest, is usually very prominent, often lasting more than 45 minutes in the morning. Patients can also have constitutional symptoms like fatigue, malaise, weight loss, or low-grade fever. On exam, the muscles in the avected girdles might be tender to palpation, but again, you won't find objective weakness or muscle atrophy.
Investigations. What did the tests show?
The hallmark laboratory finding is markedly elevated. Inflammatory markers. ESR and CRP are typically very high. That's key. Blood counts might show a mild anemia, anemia of chronic disease, or sometimes high platelets, thrombocytosis. Importantly, muscle enzymes like CK are normal, and muscle biopsy would be normal. You need to rule out other conditions that can cause similar symptoms, like RA, hypothyroidism, malignancy, and actively screen for any symptoms suggesting concurrent GCA, headache, vision changes, jaw claudication. Your notes do caution, however, that a small percentage, maybe up to 5%, of patients with definite PMR can have normal inflammatory markers of presentation, which can make the diagnosis trickier.
And treatment for PMR.
Corticosteroids are the cornerstone of treatment and are dramatically effective. The goal is symptom relief. The typical starting dose is relatively low to moderate prednisone, usually 12.5 to 25 milligrams per day. Your notes emphasize a really important diagnostic clue. A lack of significant improvement within a few days of starting this dose should make you seriously reconsider the diagnosis of PMR. The rapid response is expected.
How long is treatment needed?
The steroids need to be tapered very slowly, often over a year or even longer, based on symptom control. Relapses are common, maybe 50% of patients, during the taper or after stopping, and they usually require increasing the dose again temporarily. It's crucial to monitor for steroid side effects during this long-term treatment, provide osteoporosis prevention, and continually assess for any developing symptoms of GCA. An important point from your notes: don't treat an isolated rise in ESR or CRP as a relapse if the patient is clinically well. Treat the patient, not just the lab test.
Okay. Fibromyalgia is another common non-articular condition causing widespread pain. How is this different from PMR?
Fibromyalgia is quite different. It's defined by chronic, lasting more than 3 months, widespread musculoskeletal pain affecting areas in the upper and lower body on both the left and right sides, and the axial skeleton, neck, back, chest, often accompanied by characteristic tenderness at specific points. Crucially, it's considered a non-inflammatory condition in the traditional sense. The pain isn't thought to come from inflammation in the muscles or joints themselves, but rather from abnormalities in how the central nervous system processes pain signals, leading to heightened pain sensitivity, central sensitization.
How is fibromyalgia diagnosed now? Your notes mention the newer criteria, Table 31.
Right, the diagnosis has moved away from just counting tender points. The 2016 ACR diagnostic criteria use a combination of a widespread pain index, WPI, which is a score based on the number of body areas where the patient has had pain in the last week, out of 19 areas listed, and a symptom severity, SS scale score. The SS score assesses the severity of fatigue, waking unrefreshed, and cognitive symptoms, fibrofog, plus the extent of other somatic symptoms. A patient meets the criteria if they have a WPI score of 7 or more and an SS score of 5 or more, or if they have a WPI of 3.6 and an SS score of 9 or more, provided the symptoms have been present at a similar level for at least 3 months and there's no other disorder that would otherwise explain the pain.
Who typically gets fibromyalgia?
It's much more common in women than men, maybe 3.1 ratio or higher, often with onset between the ages of 25 and 45, although it can occur at any age. Prevalence is estimated at 2 to 5% of the population. It often overlaps with other conditions like chronic fatigue syndrome, irritable bowel syndrome, IBS, migraines, and there's a strong association with psychological distress, anxiety, and depression, though it's not considered purely a psychiatric condition.
What are the common symptoms besides the widespread pain?
Profound fatigue, non-restorative sleep, waking up feeling tired even after a full night's sleep, and cognitive difficulties, trouble with concentration, memory, finding words, the fibrofog, are considered core symptoms along with the pain. The pain itself is often described as diffuse aching, burning, or stiffness, and it's often aggravated by physical activity, stress, poor sleep, or even changes in weather. Patients might feel like their joints are swollen, but the key finding on physical exam is usually normal joints but widespread tenderness in soft tissues upon palpation.
Other symptoms.
Neurologic type symptoms like increased sensitivity to pain, hyperalgesia, pain from stimuli that shouldn't be painful, allodynia, numbness or tingling, paresthesias, are common due to that central sensitization. And associated syndromes are frequent, like IBS, interstitial cystis painful bladder syndrome, tension headaches or migraines, restless leg syndrome, obesity, and mood disorders like depression or anxiety.
Investigations. What tests are done?
A key point from your notes is that laboratory tests are typically normal in fibromyalgia. Basic blood work, maybe including thyroid function tests, TSH, to rule out hypothyroidism, is often done initially. But your sources provide a really important practical insight here. Do not routinely order extensive autoimmune tests like ANA or RF just to screen for fibromyalgia. These tests are usually negative, and false positives are common in the general population, which can lead to unnecessary anxiety, further testing, and misdiagnosis. The diagnosis of fibromyalgia is primarily clinical, based on the history and meeting those diagnostic criteria after excluding other potential causes. Sleep assessment might be considered if a sleep disorder is suspected.
Treatment sounds like it needs a multifaceted approach, focusing on managing symptoms and improving function.
Absolutely. And importantly, non-pharmacological approaches are foundational and often considered first line. Your sources strongly recommend patient education about the condition and graded exercise programs, including both aerobic exercise, like walking, swimming, biking, and resistance strength training. These have the best evidence for improving pain and function. Other non-drug approaches with some evidence include cognitive behavioral therapy, CBT, to help patients cope with pain and associated symptoms, acupuncture, hydrotherapy, pool therapy, and meditative movement therapies like Tai Chi or yoga.
What about things that don't work?
Your notes explicitly list several modalities with no good evidence of benefit in fibromyalgia, including biofeedback, chiropractic manipulation, hypnotherapy, and mindfulness meditation alone, though it might be part of CBT.
And pharmacological therapy.
Medications are used mainly for symptom relief. They are not curative. Your sources mention several options. Low-dose tricyclic antidepressants, like amitriptyline, taken at bedtime can be helpful, primarily for improving sleep quality and reducing pain. Certain SNRIs, serotonin norepinephrine reuptake inhibitors, specifically duloxetine and milnacipran, are FDA-approved for fibromyalgia. And certain anticonvulsants that affect nerve signaling, pregabalin and gabapentin, are also FDA-approved or commonly used. Simple analgesics like acetaminophen or tramadol might be used for pain interfering with function, but your sources strongly advise against the use of chronic opioid therapy in fibromyalgia due to lack of efficacy and potential harms.
What's the prognosis for fibromyalgia?
It's typically considered a chronic condition, with symptoms often waxing and waning over time, sometimes triggered by stress or other factors. While it doesn't cause joint damage or increase mortality, it can significantly impact quality of life, function, and workability. Management focuses on long-term coping strategies, symptom control, and maintaining function.
Your sources include a really helpful comparison table, Table 32, summarizing the key differences between inflammatory myopathy, PMDMM, polymyalgia rheumatica, PMR, and fibromyalgia. This feels incredibly useful for differentiating these conditions, which can sometimes present with overlapping symptoms like pain and fatigue, especially early on.
It absolutely is. That table is a great quick reference. It clearly contrasts them based on key features like typical age of onset, whether there's true muscle weakness, yes, in myopathy, no in PMR fibro, the pattern and location of pain and stiffness, the hallmark investigation findings, elevated CK and abnormal biopsy in myopathy, markedly elevated ESR-CRP in PMR, typically normal labs in fibro, and the primary treatment approaches, immunosuppression for myopathy, low-dose steroids for PMR, multimodal non-drug, and symptomatic drug therapy for fibro. Keeping those key differentiating features in mind, as summarized in that table, is really helpful for clinical practice.
Definitely. That effectively covers the non-articular conditions, highlighting how they differ fundamentally from the problems originating within the joints themselves.
Right. Different mechanisms, different approaches.
So we've navigated through a really tremendous amount of information, all drawn directly from your source material, from the basics of joint structure and immune responses, right through to the specifics of conditions across several major categories like OA, RA, SLE, spondyloarthropathies, crystal diseases, PMR, fibromyalgia.
Wow. Your notes also include just a brief overview of the overall treatment landscape.
Right, just as a quick summary, pulling together the range of tools mentioned throughout the sources for managing these diverse conditions. It reinforces the breadth of options available. You've got the non-pharmacological strategies, which are fundamental for many conditions, especially OA and fibromyalgia, things like exercise, weight loss, physical and occupational therapy, self-management techniques.
Then the pharmacological options, which range from simple analgesics like acetaminophen to NSAIDs and COX-2 inhibitors to corticosteroids used locally via injection or systemically. Then the conventional DMARDs like methotrexate, sulfasalazine, hydroxychloroquine, leflunomide for inflammatory arthritis. And then the more targeted therapies like the biologic DMARDs, anti-TNFs, anti-IL-6, anti-IL-17, etc., and the small molecule inhibitors like JAK inhibitors. And finally, surgical interventions like joint replacement for end-stage joint damage when other measures fail. That common medications table for OA treatment specifically mentioned in your notes is a good example of that typical stepped approach to therapy, starting simple and escalating as needed.
Yeah, it gives a good sense of the overall toolkit described in the sources.
Exactly.
So we have really unpacked this complex stack of rheumatology nuts together. We've distilled the core concepts, the critical distinctions, inflammatory versus degenerative, seropositive versus seronegative, and the key features of so many conditions. But let's bring it back to the listener. Why does having this deep dive specifically into your source material really matter?
Well, I think the real value here is getting that clear, organized view of the most important information presented in your specific notes. Understanding those fundamental distinctions we kept coming back to, inflammatory versus degenerative pain patterns, knowing which serological markers are truly useful versus which ones might be red herrings, recognizing the patterns of spondyloarthritis, differentiating the crystals, and crucially, knowing those medical emergencies that require immediate action. This is the shortcut your sources provide. It helps you navigate conversations, understand reports, or just make sense of this incredibly complex field without getting totally lost in the weeds.
Yeah, it feels like it's about getting to those aha moments more quickly, like realizing, okay, that's why they asked about morning stiffness duration, or understanding that a negative ANA is actually pretty reassuring if you suspect lupus, but almost meaningless if you suspect fibromyalgia, or seeing how evidence-based things like exercise truly are for OA. These are the practical insights that jump out when you synthesize the material like this.
Exactly. It's about recognizing the patterns your sources emphasize, knowing the key red flags they highlight, understanding the rationale behind the investigations they discuss, and appreciating the principles guiding the treatments they outline, all filtered through the specific lens of the material you provided. It's really about equipping you with the framework contained within those notes.
It's like building a reliable mental map based on the terrain you gave us to explore.
Precisely put.
Well, that was quite a journey, quite a deep dive into the world of rheumatology, all powered by your source material. We've covered an immense amount of ground, from the microscopic world of immune cells, antibodies, and crystals, all the way to the widespread systemic impact of many of these diseases.
It really underscores the incredible interconnectedness of the body, doesn't it? How subtle dysfunctions, particularly in the immune system, can manifest in such diverse and often profoundly impactful ways, from a single painful joint to multi-organ failure. And thinking of conditions like fibromyalgia versus, say, polymyalgia rheumatica, as your sources laid out, also reminds us that pain isn't always about visible inflammation or structural damage you can see on an X-ray. Sometimes it stems from these really complex processes related to pain signaling and central sensitization itself.
Absolutely. And seeing the range of treatments described in your notes, from foundational lifestyle interventions like exercise and weight management, which have strong evidence for conditions like OA, all the way to these incredibly sophisticated targeted biologic therapies and small molecule inhibitors hinted at by trials like TULIP-2 for lupus, it really shows the ongoing evolution in understanding and tackling these challenging diseases.
It does. And it kind of leaves you considering that for many of these conditions, while we have increasingly powerful tools to manage symptoms and modify the disease course, the fundamental why, the ultimate trigger, or the precise mechanisms driving the loss of tolerance is often still being fully unraveled. This journey through your sources really underscores the importance of careful clinical observation, recognizing those key patterns, leveraging diagnostic tools wisely but not excessively, and consistently applying evidence-based strategies, both pharmacological and non-pharmacological, to improve patients' lives.
Indeed. A lot to think about. Keep exploring those insights gleaned from your source material. There's always more to discover in the deep dive.